still can hear you.
Hi, everybody. Thank you for accommodating my talk today over Zoom. I am thrilled to be here. So I am the co-director of the Mid-Atlantic Center for Children's Health and the Environment. For those of you who may not know what that is, we are the Region 3 PACU, which is the Pediatric Environmental Health Specialty Unit. We're one of just a few PACUs that are nurse-led. So myself and my co-director, Ruth McDermott Levy, are both nurses. Ruth is an environmental health and public health expert, and I represent the pediatric and the neonatal side of the process. We cover Pennsylvania, Delaware, Maryland, DC, Virginia, and West Virginia. I have to do my general acknowledgements just because MACHI is supported by a grant from ATSDR and the CDC, and the National Public Health Institute is our National Program Office. So my talk today is really to bring prematurity to the forefront for all of you. I'm not sure exactly who's in the room. I know we're all pediatric scientists or researchers or people who care about children or care for children. Prematurity and neonatology is not always well represented in that bucket. I learned a long time ago that as a pediatric and a neonatal nurse practitioner, when I wear my pediatric hat, we tend not to think a whole lot about the NICU. And when we're standing in the NICU, we tend to not think a whole lot about what happens after we leave. So I'm hoping you'll all learn a little something new about prematurity and about why it matters across the lifespan. And I don't have any disclosures, but I typically come with a warning label. And that is to get you to start to think about prematurity and that it is more than meets the eye. Just to make sure we all have a common language. I never start to talk about prematurity without just rooting ourselves in terminology. Prematurity is by definition birth before 37 weeks. We have gestational age categories that run from early term birth, which is the 37 to 39 weeker, to extremely preterm birth, which is birth less than 28 weeks of gestation. We also break prematurity back down in terms of weight categories: low birth weight, very low, and extremely low birth weight. 20 years ago, when I started in the world of neonatology, I would have told you that the edge of viability was somewhere around 23 to 24 weeks. And my neonatology colleagues who had been practicing for 20 years or more would have told you it was 28 weeks at the time when they were practicing. We have worked that edge, I think, probably as far as it can go. The majority of preterm births in the US occur between 32 and 36 weeks, which means that the majority of preemies look more like the child at the bottom of the screen than the child at the top of the screen. The child at the top of the screen is actually a friend of mine. She is a 37-year-old at this point. She was born at 26 weeks of gestation and weighing 15 ounces. She was definitely small for gestational age. I also think we do ourselves a huge disservice if we don't talk about history and put prematurity in context, because when we talk to people about prematurity, very often they assume that the technology that we have now has always existed. And the reality of neonatology and neonatology as a science is that it has really evolved in my lifetime. So in the 1870s, about 230 per thousand live births was the infant mortality rate. The things that we needed to overcome were hypothermia, respiratory distress, infection, and weight loss. Guess what? They're still the things we need to overcome. 50 years later, we move into finally having something that's an alternative for breast milk. In the 1920s, it was evaporated milk, Caro syrup, and a little bit of rum in there for good measure. In the 1930s and the 1940s, there were World's Fairs exhibits called incubator rooms that allowed people to view preterm infants that were being treated by the nurses in these specialty rooms for a fee. And in the 1939, there's this fantastic Life magazine article that covered Boston Lying-in Hospital's incubator rooms. So they were, the height of technology at the time. Along this time, we also had the first tube feedings occurring, which was literally a red rubber hose, and to deliver breast milk or for children that were unable to suck, swallow, and breathe efficiently. Prematurity changed after the 1960s. Patrick Kennedy was born in 1963 at about 34 weeks of gestation, a gestation that today would have had a 99% survival rate. Patrick died at 2 days of age because we did not have a ventilator small enough at the time to deliver adequate and stable respiratory support to an infant of that size. There was one in Toronto. Dr. Maria Delvora Papadopoulos was working on the baby bird at the time. I had a great pleasure of working with her at St. Christopher's Hospital for Children, and she was just a truly amazing, amazing woman. But what Patrick's short life did for the field of neonatology is to shift the focus of U.S. Researchers and U.S. clinicians to the care of neonates. And neonatology as a subspecialty was evolving by the late 60s and became a fully recognized specialty with NICUs by the 1980s. By mid-1980s, we had appropriate ventilators and tubing and diagnostic catheters small enough to be used on preterm infants. And when I do that very abbreviated overview of history, because when I talk to students and when I talk to adult preterm birth survivors, they don't understand why we don't know more about how adults experience prematurity in their lives. And it's good to take a step back and say, well, we didn't actually expect you to survive this long. Or in the 1970s, you would not have survived this long. So I was born in 72. I would not have the same survival rate that the people that are being born preterm today would have. And students are always shocked by that when we bring this up. I do a pretty extensive history of neonatology lecture to undergraduate students at Villanova, and we have a lot of chins dropped on the floor when we talk about exactly the timing and the evolution of prematurity. This is an absolutely awful slide because it's very hard to read, but what I want you to get from this image is that preterm birth rate has been stable in the US for decades, with the exception of a small blip in 2006, 2007, we really have had a very stable preterm birth rate. And 2/3 of preterm births occur worldwide without an identifiable cause. And I usually caveat that by saying without a currently identifiable cause, because I believe that the research that's being done, the microbiome research, the environmental health research, there is so much to be done to look at what's contributing to preterm birth. And I do believe we'll be able to change that phrase in the next 10 years or so. When we think about the known risks for prematurity, we typically think about prior preterm birth, preeclampsia, those are the things that we know to be risk factors. But when we think about overall preterm risk, we're thinking about significant risks for women of color, women who have had a prior C-section, women who've had a prior preterm birth. Their risk of delivering a subsequent preterm birth is about 48%, as opposed to someone who has none of those risk factors, which the preterm birth rate or risk of preterm birth without any known risk factors is about 4%. This came from a 2016 article by Farrow et al. I don't know how well we can trust those numbers, but what I can say is that preterm risk increases with more risk factors that we have, and because we don't really know what all those risk factors are, we don't exactly know what those numbers are. To put preterm birth in the United States in context, we are doing a abysmal job of managing preterm birth rates. The March of Dimes goal sets preterm birth rate at less than 8%. There is exactly one state in the United States, it's Vermont, which has a birth rate below that, preterm birth rate below that goal. They are at 7.7% in 2023. Overall, the US gets a D+. You'll see that southern states have higher preterm birth rates. Alabama 12.9, Georgia 11.8, Texas 11. The western states, California, Oregon, Washington, they're a little bit better, as well as New Hampshire and Maine have a little bit better. The state of Pennsylvania, where we are right now, has a 9.7% preterm birth rate. So there's a lot of work to be done here in the US. Why does it matter, right? We always want to start with so what, right? Kids survive. We have an excellent preterm birth rate. So why does it matter so much? What we know from years of research is that as children age, they come out of the NICU, most of them well. They have great outcomes, but we have an increased risk of pulmonary, cardiovascular, and metabolic conditions as they move through adolescence and into adulthood. And what do I mean by that? What I mean is that kids that are born early have a significantly increased risk of hypertension, of restrictive lung disease, and some endocrine and metabolic conditions that are commonly seen in the population, but are seen much earlier and in greater rates in people that are born early. Casey Crump in 2020 determined that from a Scandinavian data set that preterm birth itself confers a 30 to 50% higher all-cause morbidity from age 18 to 45. Casey Crump does a lot of work with the Scandinavian data sets because they have great birth cohorts and are able to data mine in a way that we can't do quite as well here in the US. We also know that individuals that are born early have an increased risk of mental health and behavioral conditions. This is all mental health and behavioral health conditions, anxiety, depression, down to schizophrenia. So again, we see a lot of anxiety and depression in term individuals as well, but the numbers are much higher in people who are born early. There are increased risks of learning differences that persist throughout adolescence and into adulthood. And all of this leads to early onset of many of these chronic conditions. There have been some more recent publications than the Crump 2020 paper to suggest that increased risk of chronic kidney disease and lower kidney function in individuals that are born early, which makes sense. We have if we're born early, we are born with less nephrons, and the risk of chronic kidney disease is not minimal. The Rhode Island preterm birth cohort, which has, I did some work with Mary Sullivan in that group, in their 30 to 35 year, so it was their 10th wave, out of 185 people that were born preterm, we had 2 kidney transplants. So that's a statistical anomaly there. We do know that the earlier someone is born, the smaller they're born, the increased risk, but we shouldn't assume that the kids that are born between 32 and 36 weeks, that their risk is 0. Kajante looked at late preterm and early term and also found increased mortality, increased risk of non-communicable diseases like diabetes, asthma, and stroke, cognitive disabilities, and educational attainment as well. So are you discouraged? When I start that, you start to see people's faces fall and they go, oh, but my cousin Tommy was born early and he seems to be doing fine. And absolutely they are. Everything that I'm talking about is risk. It's not guaranteed. So how does all of that tie into environmental exposures? Well, when we talk about the environment, we are talking about an exacerbation or a piling on of risk. So when we think about the population of folks that were born early, they have one risk because they were born preterm. Their environment itself may pile on to that risk. It may add additive risk factors. So I'm hoping that by the time we get done with this presentation, that when we're doing environmental health research and we're thinking about how the environment affects children in general, that we start to identify who in those cohorts are born early so that we can really measure and really identify the risks to folks born early, and figure out what risk is modifiable. Whenever I talk about adult outcomes of people born preterm, there will be someone in the audience who raises their hands and says, well, I can't change the fact that they were born early, so what do you want me to do about it? And where I want you to put that thought is, there was a time, and it was within my lifetime, where we actually didn't ask about smoking risk or smoking history. We didn't ask about family history of heart disease. When I was 6 years old, I visited my father after his first heart attack in the smoking lounge at the hospital. Okay. I am not kidding. He had a heart attack. He spent, 2 weeks in the hospital, and we went to visit him in the smoking lounge. Oxygen tank and his cigarettes. So this is, I see preterm birth as a part of a component of past medical history, analogous to when we started to ask questions about smoking. Okay, so everybody in the room, when you're caring for patients, you have to ask about preterm birth history. So we're going to focus on some environmental exposures today, because that's really what we want to talk about. But I just, have to always put preterm birth into context here. So there are environmental exposures that contribute to the risk of delivering preterm. Tobacco exposure. So, prenatal tobacco exposure is linked to preterm birth. It's linked to fetal demise. It's linked to growth restriction. We know that prenatal exposure to tobacco, and I'm very deliberate in saying prenatal exposure because it's not just maternal smoking. It's the context within that the pregnant person is living within. So that's exposure to smoking in the household where they work. So tobacco smoke is a source of cadmium, which has been shown to be related to preeclampsia. So even if mom's not smoking, but she's exposed to smoke, it can increase her risk of developing preeclampsia. Extreme heat, as we're experiencing this summer here in Pennsylvania, triggers oxidative stress and inflammatory cascades within the body. It increases the risk of dehydration, which makes the uterine, it decreases uterine placental blood flow, which increases contractility. So we get this cascade of contractions, preterm labor that could lead to premature rupture of membranes and early delivery. Those are the sort of outward signs, right? We also have pollution and air toxins from wildfires, which we see a direct correlation between maternal wildfire exposure and low birth weight and preterm birth. Those are sort of things that happen distal to the family, so it's the distal environment. But when we think about wildfires and other natural disasters, the flooding that's occurring, all of those things also have a proximal environmental risk that increases risk of maternal depression, impair the family's ability to provide a safe and nurturing environment, impair the resources and their access to resources. All of those things are also going to increase the risk of preterm delivery and potentially negatively affect the outcomes of the people that are born early. Environmental lead exposure. So once the child is born, but also while the child is in utero, we have some pretty strong evidence that suggests that exposure to lead, especially in the first trimester, leads to increased preterm birth rates. Current ACOG guidelines actually say that you don't need to test for lead in a pregnant woman. You use some risk-based screening. I will stand on a street corner and hold a sign and beg people to do first trimester lead screening, or gosh, even better, pre-pregnancy lead screening as a primary prevention effort to make sure that we've corrected the lead exposure and also correct any nutritional deficiencies like calcium and iron and vitamin C, which would reduce the lead absorption to the fetus. So I'm a big fan of lead prevention. So, and that is one of the, one of the hallmarks of MACHI is that we look at the reproductive family as well as the child. So we are always talking about pre-pregnancy exposure to lead. I love this graphic from Wida et al. From 2024. It was a systematic review and meta-analysis that shows how climate change degrades child health overall. You'll see that preterm birth is listed related to heat extremes, cold extremes, and poor air quality. This is suggesting that preterm birth is a sequela or a risk when we have heat extremes, cold extremes, and poor air quality. I also choose to interpret this that the children who were born early that are then exposed to heat extreme, cold extremes, and poor air quality are themselves at greater risk. So we want to think about our preterm born population in any of those contexts. What makes preterm kids so vulnerable? Lungs, right? Preterm lungs are underdeveloped at birth. They have fewer alveolar sacs. Surfactant itself is a substance that overcomes surface tension to keep airways open. It doesn't occur naturally until after about 34 weeks of gestation. And artificial surfactant did not become available until after the mid-1990s. So when we are talking about, so my colleague whose picture I showed you, she is 37, she is a pre-surfactant child. So her lung disease is significant. And she definitely struggles when she lives in the UK. She definitely struggles when she spends more time in the city than outside of the city. Immature lungs lead to respiratory distress and chronic lung disease, or BPD. It's a long-term respiratory it's an insufficiency. However, research suggests that even without the diagnosis of chronic lung disease or RDS, children who were born early, as they age, have reduced lung function and increased incidence of wheezing, independent of their BPD diagnosis. So that's important for, say, those 30 to 35 weekers who had a little bit of lung disease but did well. They were off the ventilator. They went home with no respiratory support. Smith and et al. In 2024, they're an Australian group. They looked at a post-surfactant sample of children 9 to 12 years of age. 32% without BPD have had at least one respiratory hospital admission in their lifetime. So these are kids that were born early. They had no BPD diagnosis, but they've had at least one respiratory hospital admission in their lifetime, compared to 59% who had a BPD diagnosis. And children who had an early life respiratory admission had increased risk of reduced lung function. And as they age, they are seeing a COPD-like condition that occurs in early adulthood. Sharon McGrath Morrow from Children's in Philadelphia, she talks about, oh God, I'm going to blank on the new language, but it's an adult preterm lung disease, right? So it's this lung disease that we're seeing in people that were born early, and it is COPD-like in that the measurements look like COPD. But what the adult pulmonologists are seeing is that it does not respond to COPD meds. So Francine Polliver, she likes to use the term COPPD, so chronic obstructive preterm pulmonary disease, to reflect that this is a different type of COPD, but from a lung function standpoint, it measures as if it's COPD. We really need to do some work in this area. I spoke at the CHOP Chronic Lung Disease Conference and was just, there are not enough neonatologists and pediatric pulmonologists who really understand what these adult outcomes look like. And this is important for us because this is a modifiable risk. And if environmental exposure is adding to the risk for the preterm kids, then we need to do something about the environment. Because if we've seen that we really can't do anything about the preterm delivery, we need to do something about the next. And I am so running out of time. So let me skip ahead a little bit. Brain development. I didn't realize I got going. Sorry about that, folks. Lead, again, environmental pollutants and lung disease. Whether we have particulate matter, PAHs, volatile organic compounds, all of these, as well as lead, all of these things are additive to that child who was born early. So they're important for all children. They are even more important for the children that are born early. And we talked about this, prenatal life, the environment, and COPD risk. I love this model. Brumberg and Shaw put this model together. Some of the work that I have published uses this model and is definitely something that perpetuates this, the importance of the environment and biology on poverty and preterm birth.